Okay, hello everyone, welcome back. So we will continue to our next panel. So this is for Dr. Chan Pei Fong session. With 15 years of services, she was graduated and proceeds with specialization in emergency medicine at the University of Malaya. Then she continued her fellowship in emergency and critical care ultrasound from the World Interactive Network focused on critical ultrasound, Winfocus. After that, she continued her subspecialty training in emergency medicine, critical care, and continued with clinical fellowship with intensive care unit at Chinese University of Hong Kong. She also have a certified Advanced Paediatric Life Support from UK. Dr. Chan also active in publication with the latest publication on transesophageal echocardiography at the Golden Hour identification of blunt traumatic aortic injuries in the emergency department, with the title Pediatric Emergency, What's New? By one and only Dr. Chan Pei Fong. Please welcome.
Thank you, Mr. Chairman. I'll be talking about what is new in pediatric emergency. I'll go through 3 cases. The first case is will be a child with AEBA in the COVID era. Second case will be the pediatric cardiac arrest. And the third will be a new syndrome. It's called MISC, multisystemic inflammatory syndrome in children, which has just recently emerged in this pandemic. So case 1, this child is 7 years old, came with a known case of bronchial asthma, came with fever and shortness of breath. He has no COVID contact. His vitals are practically a bit tachycardic, tachypneic, and he has got generalized bronchi. What is the management of this patient? In the old days, this child will definitely get a nebulization. However, current evidence says that it is unknown whether nebulization or cough during the nap disperses aerosol, flies virus into the environment. So whether the administration of nap increases the risk of healthcare worker developing COVID is still unclear. At present, the CDC of US recognized 3 ways of coronavirus transmission. The first is the small droplets. When we talk at a near distance or we cough, these droplets will end up in another person's eyes, mouth, or nose. And this can lead to coronavirus infection. The second is formite. Formite is when the droplet falls onto the surface of any area, whether it's your books or your table, and another person touch that virus and touch his own mucosal membrane, that can lead to formite transmission. But this is quite rare and is not really proven to be a true source of infection. The third is airborne transmission. How do we differentiate whether it's a droplet or airborne transmission? It's based on the size of the virus. So at the moment, if the size is about more than 5 micrometer, it is considered droplet. So once you cough, the droplet that is a bigger size, it will drop to the ground, or it will drop to another person's mucosal membrane, and that causes droplet infection. However, when there's aerolization of the droplets, meaning in terms of we call aerosol generating procedures, such as cough and other procedures, then this droplet become aerosolized into the air and become very small, less than 5 micrometer, and that can become airborne transmission. This kind of transmission usually occurs if there is no ventilation in the room. However, with ventilation, the aerosols can actually disperse off and become droplet again. So the current international guideline in asthmatic patient proposes a risk stratification that aim to avoid nebulized therapy when possible. This is the latest algorithm provided by the British Thoracic Society. To avoid the risk of COVID, NAP should be provided only for those patients who have severe asthma or life-threatening asthma. And if Nebulization is really needed. It is recommended, if possible, for the patient to be in a negative pressure room with AGP, PPE, and also in a very controlled manner with no other people around. Lately, the World Allergy Organization went to the extreme of saying even severe acute asthma, it is recommended to start off with metered dose inhaler, MDI first, because of the limitation in the number of PPE available at the moment. So MDI 10 puffs are recommended 3 times in 1 hour, regardless of the age. While the therapy is in progress, give the treatment, other treatments such as prednisolone or MPECCA early so that the efficacy of the drugs are increased. However, in life-threatening features such as silent chest, cyanosed, or patient is unconscious, then you have no choice but to give nebulization. But in this kind of patients, please make sure the staff are protected with proper PPE. So in this, the last Cochrane meta-analysis on 39 studies, it's actually found that there is no difference in the efficacy of giving MDI with spacer and also nebulization. Neither is more superior than the other. But these studies exclude people with life-threatening asthma. So the take-home message for this scenario is, for asthma attack during COVID era, please give metered dose inhaler with spacer instead of giving nebulization. The second case is a 3-month-old child. He's admitted for poor feeding, and he was a bit tachypnic and a poor saturation of 94%. So a COVID swab has been taken, and the PCR is pending. So a staff nurse is giving the feeding via a level 2 PPE. Halfway through the feed, the child became unresponsive and developed a cardiac arrest. In the pre-COVID era, these were the recommended steps. There will be a call for help, and more people, lots of people will come in a crowded environment. The child will have a cardiac pulmonary resuscitation. And one of the initial steps taken are the head tilt chin lift, look, listen, and feel within 10 seconds. But this has been removed from the latest guideline. And also, the crowding around the child is also not recommended. Let's just talk about the level of PPE. The CDC classified the barrier effectiveness of the gowns that we use into 4 levels. Subsequently, many countries have used this level of recommendation and modified it in usage according to the nature of the job performed. So I'm just using this as illustration. Malaysia is using something very similar. So for level 1 PPE, is for those administrative staff who's not involved in patient care, which everybody in public is doing. Just wear a good surgical mask and use alcohol rub with good social distancing. For level 2 PPE, most of the clinicians, those of us are working in the areas that we are using, is an extra face shield or goggle plus the surgical mask. This is just to add an extra barrier to our surface mucosa, our eyes and our nose or ears. These levels 3 and 4 PPE are what we call AGP PPE. We need a minimum level 3 if you have you're going to perform any procedure that can cause aerolization. So what's the difference between level 3 and 4 PPE? As you can see, the level 4 PPE is none of the patient's body surface is in contact with the air. And according to CDC, this level 4 PPE, the gown material is actually prevent the virus and blood transmission. It's a waterproof It's waterproof, bloodproof, and virus-proof for level 4 PPE. And if you are going to perform intubation, you must wear level 4 PPE, preferably with a PAPR, a respirator, to avoid virus transmission through aerosols. But the level 3 PPE actually good enough if you do not perform any aerosolized procedure, because level 3, we know that virus is a droplet transmission. So let's just go through the cardiac arrest algorithm in pediatrics. This is recommended by the Royal College of Paediatrics UK. The step 1, if you see that there is a child who is unresponsive, so you need to make sure there's no danger. So actually at this point, the danger is to the staff who is not wearing a PPE. So remember, we do not listen, look, or feel, but we just check the response and call for help. So the algorithm follows with this first question. Is the staff wearing a AGP PPE? If the answer is yes, you continue with the normal routine pediatric algorithm and follow through. But if it is no, then we do not perform any aerosolized generating procedure. We just put on the oxygen on the patient, locate the back valve mask, and attach the HME filter. And once the team that you have called arrive, then you hand over. So if you are in a non-respiratory room, I will suggest that you ask the respiratory staff who has gone up AGP PPE to move in and take over the resuscitation. So the aerosol generating procedures during a cardiac arrest include intubation, suctioning, CPR, and back valve mask. So this is the minimum. Level 3 is the minimum, at least an N95 mask that you have to wear in order to perform the cardiac arrest resuscitation. Step 2. Remember earlier we had the old way of resuscitation when more than 10 people are surrounding the child. So this is the position of those helpers. So can we remove one of them? We can remove a provider who is doing nothing and just standing by. We can remove somebody standing at the end of the bed who doesn't seem to be helping as well. We can remove the runner. We can actually remove the drug. So only left 4 important people near to the child. Those people that we have removed, they are not gone from the scene. It is just that they are standing very far away from the head end of the bed. Maybe if there is a negative pressure room, they are standing outside the room to get ready to help out. So the algorithm says limit the personnel, just not to limit the risk of exposure, but also limit the usage of PPE. And then you give the patient 5 rescue breaths with the PPE you're on. But make sure that when you're giving the rescue breath, the back valve mask is connected to the HME filter. So this filter adds an extra barrier to transmission of virus between the back and the mouth mask, whether it's a HEPA filter or HME filter. And preferably you use 2 hands to back valve mask the patient because you do not want any leakage. So when you intubate the child, there are certain precautions to take. One of it is we stop the CPR. In the old days, we do not stop CPR during intubation. In the COVID era, we do not want you to continue CPR because of the risk of the aerolization. If the patient was manual bagging, you stop the bagging and you choose the most experienced person to intubate the child. And if you have certain barriers such as a plastic bag or a box, that will be good as well. So the take-home message for pediatric resuscitation in COVID. Number 1, if possible, you already anticipate that this child is going to cardiac arrest, you wear the PPE in advance, or you put the patient in a respiratory zone. You limit the number of people involved in the resuscitation. You have a plan. You say, you allocate the roles. Who is the person standing at the end? Who is going to do the CPR? Who is going to give the meds? Secondly, for the airway and breathing, we back valve mask with the HME or HEPA filter with 2 hands to prevent leak. And you intubate early by the most experienced person so that it is successful at the first attempt. And lastly, for CPR, if possible, you place a plastic or box over the head end of the patient to segregate the AGP procedure from you, and you pause the CPR during the intubation. The third case is a very special condition. It's a child with a multi-system inflammatory syndrome in children. It's a 6-year-old kid with a fever for 5 days. He has conjunctival hyponatremia, meaning conjunctivitis. The limbs are swollen. There are some macules you can see, and the tongue or the lips are also swollen and very red. So in the old days, this condition is what we call Kawasaki disease. There's a mnemonic for it. It's called warm cream. The child is febrile for 5 days, and there's a mnemonic called cream. C for conjunctivitis, R for rash, E erythema of the palms and soles, A adenopathy, lymph nodes enlargement, and M mucous membrane, red tongue. So why is this disease so special? It's special because it causes complication to the heart. So it causes long-term coronary aneurysm and a heart disease to a child, which will be very detrimental. So there has been an increased number of COVID cases that have been related to this Kawasaki disease, but not all of them fulfill criteria. So the international people come up with a new term called MISC. And what is special about this MIC is, apart from the traditional Kawasaki symptoms, the child also presents with shock, very low BP, and sometimes this condition leads to death. So what are the definition of this MISC? According to CDC, any individual less than 21 years old present with fever and 2 organ involvement. Any organ that is dysfunction with no other diagnosis and a recent SARS-CoV-2 infection are considered to fulfill the criteria. The person do not need to fulfill all the criteria of Kawasaki disease. They just need to have some feature and also have the COVID history. That person also will have MISC. So just a bit about the epidemiology. This condition is first emerged in April 2020. Why is this so special regarding the first emergence? It's because it's found that this MISC do not occur immediately during the first COVID infection. It occurs 4 weeks to 6 weeks later. So it is a late disease, although it is associated with COVID. Actually, the child is not infectious. The pathophysiology behind it is due to the inflammatory response of the patient to the virus. The incidence, according to the latest data, is 2 in 100,000. Seems very rare, but mortality rate can be up to 1 to 2% if the child has a MISC. So the treatment, very unfortunately, is supportive, and all this use of immunosuppressants such as steroids and immunoglobulin are based on experience with Kawasaki disease, meaning they are actually not proven because the condition is quite rare. So there are currently not enough data to support what is the absolute treatment for this MISC condition. So the take-home message for MIC is, if you are living in a COVID era, in a COVID pandemic area, and you see a child who come in with Kawasaki-like disease, or the child has a toxic looking in shock, then you have to think of MISC. And in fact, even if the COVID result is negative, you need a second test to do a COVID serology to look for the antibody. Because at that moment, the child is not infectious with the COVID disease, but the inflammatory response from the body has caused this MISC condition. So the take-home message for me is prevention is better than cure. We do not want this virus to attack us or our child because of all these extra sequelae. So take precautions. With that, thank you very much.
Thank you so much, Dr. Chan Pei Fong, for a very fruitful sharing. So I do hope that we could take the message for us to apply back at our home or our own department.